Namaskar viewers, hello and welcome to Sansad TV. I am Teena, you're watching Perspective. World Malaria Day, observed every year on the 25th of April, is an occasion to raise awareness about the global effort needed for malaria prevention and control. Instituted by WHO member states during the World Health Assembly in 2007, this day emphasizes the importance of continued investment and sustained political commitment towards malaria elimination. This year, the World Health Organization is promoting a grassroots campaign, Malaria Ends With Us, Reinvest, Reimagine, Reignite. The campaign aims to re-energize efforts at all levels, from global policy to community action, to accelerate progress towards fighting this deadly disease. Malaria remains one of the deadliest diseases, affecting millions of people worldwide. The disease claims an estimated one life every minute, with most deaths occurring in sub-Saharan Africa. In India, malaria cases and deaths dropped by around 80% from 2015 to 2023, with cases going down from 11,69,261 in 2015 to just about 2,27,564 in 2023, while the deaths fell from 384 to just 83. The Indian government is committed to achieving zero indigenous cases by 2027 and ensuring prevention of malaria re-establishment. Further ahead, India remains steadfast in its goal to eliminate malaria by 2030. So in this edition of Perspective, we'll talk about how India succeeded in significantly reducing malaria cases and malaria-related deaths between 2017 and 2023, what marked the turning point in India's fight against malaria, and how we are progressing towards achieving malaria-free status by the year 2030. Joining us on the program are two distinguished guests. So let me begin by introducing them to you. I'm delighted to welcome Mr. Alex Eapen, Senior Scientist and Officer in Charge, ICMR-NIMR, Chennai. Dr. Eapen, thank you very much for your time. Welcome to Sansad TV. Also delighted to have with us Dr. Sunil, Raina, Professor and Head, Community Medicine, Dr. R.P. Government Medical College, Tanda, Himachal Pradesh. Dr. Raina, welcome to Sansad TV. Glad to have you with us on this broadcast. Let me begin the program with you, Dr. Eapen. And since we're talking about the remarkable progress that India has made in recent years as far as our fight against malaria is concerned, so the turning point was when in 2024, India exited the WHO's high burden to high impact group. So tell us about what key operational milestones helped India exit that group and achieve a significant progress as far as reducing malaria cases and malaria deaths are concerned.
India has had programs. Active transmission cases have come down. So it has. We have the testing facilities. So India has the malaria. The detection, active detection as well as passive detection cases have improved, and using bivalent rapid diagnostic kits, and also the vector control tools, then the drug management of cases by ACT for PF and chloroquine against PV. So these are the measures which have done. So the vector control tools include indoor residual spraying in houses, and also supplying long-lasting insecticide nets. Now we call this insecticide-treated nets in villages where people are exposed to mosquito bites. These nets will prevent mosquito bites as well as kill the mosquitoes when it comes to vector mosquito when it comes in contact with the nets.
Right.
So these are the measures which had taken, and it has drastically reduced. So there are different, and also the cases have been registered, and the cases are notifiable cases, and the notifiable cases are from the district is onto the platform, IHIP platform. So now it has been the new framework for national, framework for national strategy is strategic plan for malaria elimination. It has got malaria-free India vision. And the mission is to eliminate India by 2030. That is to bring down the cases to zero transmission, that is zero cases, and so that it can be maintained till 2030. And the goal is to interrupt local transmission, achieving zero indigenous cases throughout the country by 2027. So there are various measures, strategic plans. So in this national strategic plan, so and it has been implemented well. So therefore, the cases have been reduced. Now we have high incidence of category 3 districts. There are only 2 states, that is Tripura and Mizoram. The rest of them have become either category 2, 1, or category 0 now.
Sure. We'll speak about how a data-driven approach has further helped us identify the outbreaks and at the same time control them in greater detail. We'll come back to that aspect with you, Dr. Eapen, in just a while. But let me bring in Dr. Raina into the discussion, get his perspective. What role do you think community-based health education has played, particularly in rural areas? Because without that, we don't expect that kind of drastic reduction in numbers. So help us and our viewers understand how significant has that been in sustaining that momentum towards bringing down malaria numbers in the country.
First, thanks, Teena, for having me on the show. When we realized, maybe way back, some 20, 40 years back, we realized that this malaria is one disease which can be eliminated. Primarily because of the fact that the malaria parasite as well as the vectors for malaria doesn't have the same advantages that some other biological organisms have. So we started interventions right from then onwards, and the interventions, I broadly say it were carried out at 3 levels, where multidisciplinary approach, not tremendously restricted to one particular aspect only. So we didn't just focus on the health workers, or we didn't just focus on the doctors only. We said we will need to invest in individuals. So individuals were educated, made aware of how to take care of the fact that they're not bitten by the mosquito, how exactly to prevent themselves from getting malaria. We took it to the community and asked them, look, we need an integrated vector-borne disease control program wherein your role is key. Reduce the source wherein these mosquitoes will breed and carry the malaria to individuals. So at individual levels, we educated people. At community level, we educated people. And then we had the health system in place. The health system took care of rest of the things. We improved the diagnostics. We thought of putting the right treatment in place. So wherein we thought that, look, there is a high burden of a particular parasite, a high burden of a particular parasite type of parasite. We use one type of strategy for treatment. At other places wherein we thought that this burden is lower, we used another type of strategy. So all in all, it was a comprehensive multidisciplinary approach that helped us prevent it or make the transition from a very high burden to a high impact country in the world.
Okay, Dr. Eapen, if I could ask you a more specific question on some of the most innovative models or projects that have focused so far on malaria prevention, which have shown tremendous success until now, and which could be now scaled nationwide to achieve the desired goal of reducing malaria cases further?
I mean, as far as the surveillance is concerned, the community-based surveillance, going to the village and then tracking out the patients, checking them, and then diagnosing them and treating them, that is one aspect which is being done in rural settings. However, in urban settings, we have the passive agencies where the symptomatic patients used to come to the clinic, and they are treated based on the symptoms, and then treatment is given based on the parasite species. So we have a national drug regime, and which is being followed by the state as well as the district. And as far as the parasite is concerned, parasite control is concerned. And for vector control, so we have different measures for the larval control measures, the larval source management. It is not so. It is anti-larval treatment in the breeding habitats where the vectors are breeding. So the primary vector, there are different primary vectors. 6 of them are there. So they are either in the rural areas or in the tribal belts or in urban areas. So these are treated. And you also have, for adult control measures, you have the indoor residual spraying, which is being done in rural areas. And then provision of insecticide-treated nets. These could cut down this, the mosquito, bites, and therefore the exposure. So these studies are going on, and then you have therapeutic efficacy studies, whether the drug is effective against the the treatment given, against the parasite species. So the drug has been given and then it has been followed up, and whether it is appearing in early treatment failure or late treatment, which this is being followed up. So these studies, such studies are going on, multicentric studies are going on. So that would give whether the drug is effective against the malaria parasite species, so that the treatment according to the national drug regime can go. Then there are certain studies, specific studies on climate-based, whether the microclimate conditions are favorable for the vectors to survive the ambient temperature conditions. Therefore, whether the extrinsic incubation period in the vector is reducing, so the transmission is happening faster or not. So such studies are also there.
In the wake of the sustained efforts that India has made towards becoming a malaria-free nation, we've been talking about these innovative projects that have become a huge success, and because of which in 2023, 0 malaria cases were reported in 122 districts across various states. So from a public health education point of view, how do you think we can keep malaria prevention at the top of the mind in areas, in districts that have already achieved 0 case status?
We need to understand malaria from a public health perspective is a low-hanging fruit. If you look in terms of the disease that can be eliminated in next 10 years from now onwards, malaria is one of them. Primarily because of the fact that if you look at the spread of malaria across India at this point in time, it's not uniform. We have states which are almost free of malaria. There have been no cases for last few years now. Almost 122 districts are such districts in the country. So they set an example for rest of the districts in the country as to how exactly we get rid of malaria. That's one part of it. The second part of the story is that in order to sustain the efforts of the malaria in these districts so that these districts don't pick up malaria again, we need to keep investing. We need to keep telling people, look, you have been free of malaria for a period of time. You need to keep investing in staying it free. Right. And the best example of staying it free is, as I said, we need to continue to use multidisciplinary approach. We need to continue involving the community. We need to continue to involve the individuals as well as the strategies that are being enunciated at the central level or at the state level in that matter. Fortunately for us, there are certain districts in the country which are more likely to stay free of malaria as compared to others. So the learnings from those states need to be taken care to other states as well. We need to be careful about a few things. Meanwhile, when we are delving into it, when we are thinking of making the country malaria free, we need to understand one basic thing. Whenever the numbers will fall down, there is a chance that there may happen certain mutations, there may happen certain changes within the parasite itself, which may make a resurgence at some point in time. That resurgence may be small or a larger one. So we need to be prepared for that. As also the fact that there may be new vectors which may come into the picture as far as malaria is concerned at this point in time. We also need to be on guard against those particular vectors which are not at this point in time the dominant vectors in the country. So we need to be aware and we need to continue the efforts that we have been doing for the last 5-10 years so that we are able to make this country malaria free.
Help us and our viewers understand that with India now targeting 0 indigenous cases by 2027, what are the risks that still remain in terms of re-establishment or also cross-border transmission, if there is any probability of that? And how are we preparing for all of these aspects? These are basic questions, but important for us to understand if we are to achieve the 2027 and the 2030 goal as far as malaria elimination is concerned.
If you look at it from this point of view, as those who are in the world of economy, they will tell you the theory of diminishing returns. As long as the numbers will fall down, they will reach to a stage wherein we think that we have conquered it, doesn't necessarily mean that we have really achieved the goal of elimination. We still have cases with us, and also the fact that people around us, in terms of the countries that are surrounding us, if they have not reached the stage of elimination, we are always at a risk of malaria coming back and causing resurgence. If you look at the current strategy that country is adopting, we are not just looking at what is happening in this country, we are also looking at our neighboring countries, wherein malaria cases are there and their chance of taking it to India, getting it into India are higher. So we need to be aware of not just what's happening in the country, we also need to be aware of what's happening around the country. That's one aspect of it. Second is, as we have seen with regard to what's happening in Africa or even in the West, in Africa, we are seeing that NIMR and NIMR vectors are establishing their dominance, particularly in the urban areas of Africa. there's a chance that we will see a similar dominance of a variant of a vector in India, which has not here at this point in time been the most common vector. So we will need to adjust to the fact that this vector may come, and we have to have enough strength in our arsenal to fight this vector. Third is that we need to learn from what's happened in the West. If you look at at the US at this point in time, or if you look at even at Europe at this point in time, they were practically free of malaria at one point in time. We still find cases happening in these areas. You find them in Europe. You saw it in Italy. You saw it in Greece. You have had a few cases of malaria in the US. So as long as the travel is there, we have huge amount of travel. Since 2008, the travel has increased immensely. So as long as travel is there, there is always a chance that somebody from outside will carry malaria into our country. And then we have a chance of it causing a surge. So we have to be aware of our neighbors. We have to be aware of who comes into country and carries malaria with us. As and when we are seeing that the numbers fall to a level which will be critical for us to take care of.
Dr. Eapen, so what special strategies were you talking about which are now being implemented to ensure that malaria elimination efforts in the country are inclusive of the marginalized population, and especially you referred to the tribal communities, also the migrant laborers, because that number in India is also very high. So how are we looking at all of those aspects?
So there are specific projects going on. So, I mean, as far as the Northeast is concerned, Mizoram, Tripura, these are tribal belts. So researchers are focused on to find out with the therapeutic efficacy studies. Then there is also a multicentric household survey to find out the intervention measures taken, how the services are being used, the accessibility, acceptability. So all those measures are being, being studied. So the studies are going on, and then against the parasite, as I said, the therapeutic efficacy studies are going on, and then for vectors also, whether the vector is resistant to a particular insecticide, those studies are also being monitored. That study is also multicentric. Then there are specific studies in areas where you have issues which related to migration, the population movement, they are being tracked, and whether they have malaria fever or not, and that has been tested, and then treatment according to the parasite species are also being administered. So there are studies going on in, so that in the hotspot areas, the studies, some of these studies are tailor-made according to the needs of the local scenario. But in otherwise, in pan-India, the multicentric studies are going on specifically against the malaria parasite species as well as the vectors.
Dr. Eapen, capacity building is also something which will define the course of, how we accelerate our efforts towards our 2030 goal. So how are we ensuring sustained capacity building, especially at the grassroots level?
So the government is they are recruiting the staff as far as because the primary level is the primary health center. So the village level, the people, the villagers used to approach the primary health center. So as states are, there is, the states are recruiting those staff in the primary health center, and in specific areas where ASHAs are also taking care of the activities and going to the villages, to the household to check malaria. In addition to the malaria, other diseases also, they do such services so that the rapid diagnostic kits, and then as of now, there are the trained technician staffs are also less, so that the many advanced research is going on AI-based and machine learning methods to detect malaria parasites. Many studies are being on board, and then proposals are also ongoing on the detection of malaria. And training and capacity building is also being done at centralized level, at headquarter level, at state level also. Reorientation training programs for detection of malaria parasite species, correctly identifying the malaria parasite species and treating accordingly. In areas where you have low number of cases, the technicians may or may not find out parasite on a regular basis. Therefore, reorientation trainings are going on. And for vector-related staff, that is for interventions, the training for how to take larval sampling, how to identify the mosquito malaria vectors from the other vector species, then and all those studies are going on. So these the training and capacity building will help them to develop at the in a grassroots level and also at the district and also the state level.
Okay, Dr. Raina, a related question on capacity building and strengthening health systems, also training our workforce, something that Dr. Eapen spoke about. How, according to you, or how important is the role of local governance as well as the ASHA workers in malaria prevention, malaria control and treatment adherence?
This is very important. This is an important question in terms of the fact that I believe if you want to get rid of a disease, this is not just about malaria. Of any disease that is there as a problem in terms of its high burden, the best way of preventing that, best way of reducing that burden is to take it to the community. Making the community aware of the fact that this disease is causing a high burden, this is a cause for concern, mortality is high. ASHA plays a critical role because if you look at ASHA is based in the village. There is some high amount of trust that the villagers have in an ASHA. So the communication is easier. You just need to look at it this way. Making available healthcare services at a particular area doesn't mean that people who are living in that area will utilize the services. Unless and until those who are utilizing the services have a high amount of trust in those services. So ASHA bridges that gap. It's able to create a communication channel between a common individual and that health system. And in that sense, I always see ASHA as critical as far as delivery of healthcare is concerned. So ASHA needs to play the role of making people aware of the fact that malaria can happen. It's around us, but it's something which can be prevented. And the ways of prevention are simple. They can be carried out at the household level. They can be carried out at the village level. Once you are thinking of the village level, you can always involve the Panchayati Raj institutions, the Panchayat Pradhans. They just don't have funds which are tied or untied. They also have the resources which are local in nature, which are able to take care of the fact that the this malaria vector doesn't breed around common places in a village. So involving community will be key. The second aspect that you were asking, Dr. Eapen, was how do we build the capacity? I think the best way of building the capacity has been once we have developed that integrated health management portal. So that integrated health management portal makes it almost necessary for everybody to report on the malaria cases around them. So once you see a case of fever, once you see a case of suspected malaria, you need to go further, check it out, and report to that integrated management platform. And because of the fact that now we have a very widely established network of primary healthcare in India, we have enough number of people who are manning these primary healthcare centers. We should be able to take care of this disease in areas wherein we have the services. We will need to be careful with those areas wherein the services are less in supply, or are the districts which have a high burden of disease. Probably supplementing the services there will be the key, and probably creating more inputs in those areas will be the key. And in that sense, as Dr. Eapen said, we are investing in high burden areas, we are investing in marginalized populations, we are investing in tribal populations, we are investing in urban populations wherein the burden is high. So that in all will improve the situation as far as malaria is concerned across the country.
I'll take one last comment from you, a concluding remark on the fact that looking ahead, we are committed to becoming a malaria-free country by 2030. But in the next 5 years, how do we accelerate our efforts? Where is the attention most needed to help us reach that desired goal?
Of course, we need to focus our resources towards the high burden states now. So that is Mizoram and Tripura. These two states are category 3. And there are some areas in Chhattisgarh, West Bengal, and some pockets, hotspot areas are there. So only thing is that when the cases are coming down, when in the area, when it becomes hypoendemic, so there is a possibility that the parasites will not be detected by microscopy. So it could be submicroscopic in nature. So now that during COVID time, even at the district level, so many PCR machines were provided. So that would help us to get, even if there are cases there which cannot be detected malaria and cases in the community where asymptomatic cases also would be there. So the community-based surveys would be needed in areas where the cases, many of the districts where it has been eliminated now. We need to see that again the cases should not be appearing again. So that is something which we have to prevent, the reappearance of the cases. So that measures have to be done. So these two hardcore areas, areas where hotspot areas, the cases have to be focused. So we need to make intensified studies on the vector as well as the parasite control as well as the vector control has to be intensified, so that the intervention measures which are undertaken in these areas are in full swing. So with that, we can reduce it. And we need to see that once these areas become zero elimination or zero cases, zero indigenous cases, we need to make sure that this is sustained for another 3 years so that the elimination can be achieved. So
absolutely. So as both of you have rightly summed up, that a comprehensive multi-pronged strategy that we have adopted, which has given us a roadmap for achieving zero indigenous malaria cases by 2027, that has worked for us, that has helped us achieve significant milestones in our fight against malaria. The need now is to just accelerate the efforts that we have been making all this while. The need is to turn our attention towards some of these states that Dr. Eapen mentioned, and we should be able to, in fact, we are steadfast in our commitment to achieve that goal of becoming a malaria-free country by 2030. So that having been said, we'll have to wind up the program. Thank you once again, Dr. Raina, Dr. Eapen, for your valuable time and your valuable insights. And thank you once again for joining us on the program today. Thank you to you viewers as well for your time.
To watch more programs of Sansad TV, subscribe to our YouTube channel and don't forget to like and share them.